Thromboembolism and fetal loss. Letter of referral. Dear Dr. Re. Mrs. Annie Burns, aged 36 years. Thank you for seeing this woman with a history of a low platelet count. The most recent result checked in our surgery was 95 × 10⁹L, normal range 150-400, but this has been low over 3 or 4 years. She has suffered one instance of deep vein thrombosis, DVT, at the age of 30, but there is no family history of thrombosis. In addition, she has a history of recurrent miscarriages and has also been referred to the obstetricians. I wonder if these pathologies are linked and would be grateful for your opinion and further investigation. Yours sincerely. Introduction. Each of the 3 individual aspects of this case is a relatively common problem: thrombocytopenia, venous thrombosis, and miscarriage. However, the combination of all 3 is most likely to be due to antiphospholipid antibody syndrome. Further questions should focus on confirming this diagnosis, but do not forget to consider other possibilities. History of the presenting problem. The primary problem that the GP has asked you to investigate is the thrombocytopenia, but it is likely that the problem most distressing to the patient is the recurrent miscarriages. Establish if this is the case and discuss the miscarriages first if they are the patient's main concern, before proceeding to systematically inquire about the other aspects of her condition. Recurrent miscarriages. How many pregnancies have failed, and at what stage in the pregnancies? In antiphospholipid antibody syndrome, fetal loss tends to occur late, i.e. beyond the first trimester. Other questions related to fetal loss are likely to be better handled by the obstetricians and left to their clinic. Thrombocytopenia. Is there a history of bleeding/bruising? In particular, ask about any previous surgical or dental procedures. NB. In taking a history of a bleeding disorder, always ask directly about dental procedures, i.e. has there been prolonged bleeding after tooth extraction? Venous thrombosis. Was the DVT confirmed by Doppler and venogram, and, if so, for how long did she receive anticoagulation? Were there risk factors at the time of the thrombosis 6 years ago? Surgical procedures, immobility, smoking, oral contraceptives, and pregnancy all predisposed to thrombosis. Are any of these risk factors still present? And was this the only episode of thrombosis? Ask directly whether there have been any other instances of unilateral leg pain or swelling, or of chest pains or breathlessness that might have been due to pulmonary emboli. Other relevant history. A family history of fetal loss or thrombosis should be elicited. Antiphospholipid antibody syndrome is not inherited, but many other causes of thrombophilia may be. Does she suffer from any systemic illness? Antiphospholipid antibody syndrome is associated with autoimmune rheumatic disorders, particularly systemic lupus erythematosus, SLE, and symptoms related to this syndrome should be elicited. Ask directly about joint pain/swelling and rashes. Ask about drugs or medications. Phenytoin and phenothiazines may be associated with antiphospholipid antibody syndrome. Plan for investigation and management. Explain to the patient that a number of blood tests are required, some of the results of which may take a while to become available. Ascertain when she is seeing the obstetricians and explain, both in routine clinical practice and in PACES, that you will copy your letter to the GP to them, or even phone them, to keep them informed and prevent any inappropriate duplication of tests. FBC and film. The thrombocytopenia should be confirmed and a blood film examined to exclude platelet clumps. The rest of the FBC and blood film is expected to be normal. If not, further investigations must be undertaken. The presence of anemia, particularly hemolytic, may support a diagnosis of SLE and should trigger investigations. Neutropenia would also be consistent with SLE. Thrombophilia screen. In particular, investigate for antiphospholipid antibodies and lupus anticoagulant. Other tests. Dipstick the urine to look for proteinuria and / or hematuria, which could indicate lupus nephritis in this context. Perform blood tests to check renal function and liver function, and a screen for autoimmune rheumatic disorder, namely antinuclear antibodies, ANA, anti-double-stranded DNA antibodies, if ANA positive, and complement levels. Management. Arrange to see the patient in the clinic with results in the next 3-4 weeks. She should obviously be advised to take adequate precautions against pregnancy while investigations are proceeding, but preferably not the oral contraceptive. It will be helpful if she has also seen the obstetricians before review. Ask her if she would like to bring her partner to the appointment. Some units will have a combined hematology and obstetric clinic where it may be most appropriate to review her. Further discussion. The lupus anticoagulant is identified by a prolonged activated partial thromboplastin time, even though this is a prothrombotic syndrome. This is because antibodies bind to phospholipids on the platelet surface, interfering with clotting tests. The diagnosis of antiphospholipid antibody syndrome is a serious one, especially if related to underlying SLE. There are various support groups available for patients with recurrent fetal loss, and she should be made aware of this.